So thank you very much indeed. I'm very honoured to be invited to start the meeting off with this slightly ambitious title of a brief history of NHS politics from 1948 to 2030. Now, even taking it up to now, many books have been written on this subject. So I'm going to only give you a snapshot of a few sections of this long history. I'm going to talk a bit about the politics at the birth of the NHS and how the NHS came about and some of its birth pangs, if you like. And then I'm going to very briefly talk about three questions. One is, will the NHS ever be divorced from politics? Is the NHS financially broken? Can it go on being funded from general taxation? And performance managing the NHS, managing doctors and doctors as managers. And each of these I will give a historical perspective, and then I will get out my crystal ball at the end and try and give you some predictions for the future. And one of the things which has become very clear to me as I prepared this talk, and will be clear to you as you listen to some of the people talking in the 1940s and 50s and 60s, is that an awful lot of things which we say now about the NHS have been being said for a very long time. So there's a distinct feeling of déjà vu in a lot of what you're going to see. So let me first of all just introduce you to some of the people who will meet along the way. We're going to meet William Beveridge. We'll meet a Conservative Minister of Health. We'll meet a Labour Minister of Health. We'll meet a GP, a particularly grumpy GP, as you can see. We'll meet a Cambridge economist, another Minister of Health, a Prime Minister, and an old age pensioner. So I'm starting before 1948. I'm in fact starting in 1912, which is the National Insurance Act, which Lloyd George brought in, providing insurance for all men of working age in employment. Did not provide insurance for their wives or their families, and it was based on Bismarck's reforms in Germany in the 1880s when he had introduced an insurance system. But although that was a big landmark, it became fairly clear that it was not fully adequate. And there was a Royal Commission on National Health Insurance which reported in 1926, and there was a lot of discontent with the insurance principle at that time. And they wrote, the ultimate solution will lie, we think, in the direction of divorcing the medical service entirely from the insurance system and recognizing it to be supported from the general public fund, i.e. from general taxation. And that's what eventually came about. And it came about with, starting off with William Beveridge's report in 1942 on how health and social care should be organized. And this has really laid the foundations for the welfare state in the UK. And among the things which he said in his report was, restoration of a sick person to health is a duty of the state. And I think that you can see, if you think of some other countries around the world, if you think of the United States, for example, where many people would absolutely not accept that. And yet it remains a very fundamental feature of our health service, this sense of social responsibility. Now, the responsibility of bringing in the National Health Service, the outlines of which were in the Beveridge report, fell to a coalition government, which was in place during the war, and it's not the first coalition government we've had, the one we've had just recently. And it was actually a Conservative Minister of Health who first described what the NHS was going to be like. And it was tricky. So here is a Conservative Cabinet Minister writing a memo to his colleagues saying this is a compromise scheme, but one which is more favourable to the Conservatives than to Labour. If the discussion of the whole scheme is reopened, I fear that the Labour ministers may withdraw their support from the scheme and stand out for something that would be far more repugnant to Conservative feeling. And so you can see the tensions in a coalition government even in those times. But anyway, it fell to a Conservative Minister of Health to tell the nation what it was going to be about.
Mr. Henry Willink, Minister of Health for England and Wales, talks about the government's national health scheme.
I've been asked to tell you just a little about this new plan for better health. Our plan is a service which will provide the best medical advice and treatment for everyone, every man, woman and child in this country. Whatever your income, if you want to use this service, And nobody's going to try to make you unless you want to. There'll be no charge for treatment. The National Health Service will include family doctors, whom you can choose for yourselves, and who will attend you in your own homes when this is necessary. It will cover any medicines you may need, specialist advice, and of course hospital treatment, whatever the illness. Special care for mothers and children, and a lot of other things besides. In fact, every kind of advice and treatment you may need. This has got to be not only a full service, but also a really human and personal service. We're out to improve the health of every family and the whole nation. If we cut out the money worries which illness brings, then there'd be no reason to put off getting advice and treatment. We could build up good health instead of just trying to mend bad health.
So, of course, it fell not to the Conservatives to bring in the NHS because in 1945 the Labour Party had a landslide victory in the general election, and so of those coalition partners who'd put together plans for the NHS, it fell to Aneurin Bevan, who is widely now seen as the architect of the NHS, to bring in all the details of the scheme that we subsequently see now. Now, he faced a lot of opposition in this, not least from the doctors. So here's a cartoon of the day, Aneurin Bevan walking down the street and the surgeon's about to trip him up saying, "Here he comes, boys." And the doctors, the BMA, were firmly against the introduction of the National Health Service. And they gave a number of reasons for this. It would be probably fair to say they were most worried about their incomes and what would happen to their livelihoods under the uncertainties of the NHS, losing their independence. But they very much viewed it in terms of, publicly in terms of loss of clinical freedom. And the BMA voted on whether doctors should join the NHS, and they voted 8-1 against. So here is one of the BMA members talking.
There's something personal in medicine, something in that doctor-patient relationship, something private and confidential, which is essential to good medicine. Break into that. Make the doctor not your doctor, but the state's doctor. No longer your friend, your advocate, and you'll have done some damage to medicine that it'll be impossible to repair.
But the government mounted a pretty vigorous publicity campaign for the NHS. Every household in the country was leafleted, and indeed people were given forms in which they could sign up to the NHS. And they also publicised the news service on newsreels.
The government's plan is described by Labour MP Dr. Hayden Guest.
From the day when Parliament says the National Health Service is to come into operation, every man, woman and child, every person young and old, every person insured or not insured, will be able to get a free medical attention in the home, in the doctor's surgery, or in the hospital. And if you need it, you will get free specialist consultation and free specialist treatment in the hospital. The first thing to know is that the whole service, the doctor in his surgery, the doctor in your home, or the bed in the hospital, if you need to go there, will be free. There will be no more doctor's bills.
Anyhow, so the BMA then had a second vote on whether doctors should join the NHS, and they still voted against, but this time by a very narrow margin of only 14,000 to 13,000. And at that point, they were clearly losing. And they lost press support. The BMA will fight, but will not say what about. Amazing confusion, and doctors told, fall in line with Bevan, which they duly did. Only 5 weeks before the NHS started did the BMA advise its members that they should join the NHS. So the NHS got going. Here's a picture of Aneurin Bevan on the very first day of the NHS in a hospital in Trafford General. And off it went. And how did it go? Well, let me describe that if things carry on working in Bevan's own words. talking now at the end of the first year of the NHS. And I think that you will realise this when you hear him talk, that some of the problems which the NHS faced then are exactly the same as they face now.
The health service started, as it must inevitably do, I think, in any part of the world, in an atmosphere of friction, of controversy, of doubt, and of great hopes. The first year has revealed what we all expected: a vast amount of silent good work, a great deal of relief, and a great deal of gratitude, but frictions at this point and that point, shortages. It's obvious that in some parts of the country the GPs are overworked. It is obvious that it will take some years for the scheme to bed itself in. More facilities will be needed before criticism will die down. One of the chief sources of our troubles here in Britain, and not only here in Britain, but in many other parts of the world, is the increasing demand made upon hospital facilities by the aged sick. One of the great problems of modern civilization. But I would have you realize, if I may, that most of the shortcomings which have been revealed by the British Health Service are not the result of the intrinsic defects of the service itself, but because of the overwhelming volume of need that the service itself has revealed. And this will happen, I venture to say, in other nations when they start the same kind of service. That there has gone on in the past a vast amount of silent suffering, a vast amount of remediable pain. And what a national health service does is to, first of all, make it articulate. And to the extent that it makes it articulate, men are driven to redress it. And I believe in Great Britain we have made a great start.
So you can see that right at the start, the NHS was intensely political in the way that it started off. And my first question then is, can the politics ever be taken out of the NHS? Bevan, I think, was fairly clear that it could not. The first quote is as if a bedpan is dropped in the hospital corridor in the valleys of Wales, the sound should reverberate in the Palace of Westminster. And this is probably an apocryphal quote. Nobody's actually been able to find out an actual verbatim quote, but it was certainly Bevan's view that he, as Minister of Health, in a sense, had direct responsibility for what was going on the ground. A direct quote that he did make when giving a speech to the Royal College of Nursing in that first year was, "Every mistake which you make, I will bleed for. I shall be going about like St. Sebastian, bleeding from 1,000 javelins," something that I am certain that ministers of health over the years have felt acutely. And indeed, they have tried to do something about it. So they have tried successively to divorce the NHS from politics, sometimes very physically, by moving it up to Leeds. So we have this wonderful Stalinist building where the NHS executive located itself. And over the years, successive ministers of health have said, we want to divorce the running of the NHS from politics. Most recently, Andrew Lansley, who wrote, "We want to create an NHS free from day-to-day political interference." Well, that hasn't quite happened, has it? And indeed, Alan Johnson, who's a very articulate commentator on the NHS, when he was talking about that in his interview with Nick Timmins, said, "There was no way I would have pursued that." He was a previous Minister of Health. It was never going to work. Parliamentarians aren't going to put up with being told nothing to do with us, write to NHS England. And just to show that he was putting his money where his mouth is, he went on, when Mid Stafford broke, Bill Moyes, who was the Chief Executive Monitor, was trying to tell me it was his responsibility, not mine, to remove the Chairman and Chief Exec of the Trust. But I told him, piss off, I'm dealing with this. So I think there is, if we're looking ahead, there is absolutely no prospect while the NHS is funded out of general taxation, that ministers will ever succeed in distancing themselves from the day-to-day trials and tribulations of the NHS. They have tried to do so numerous times, and it simply doesn't work. So the next question I'm going to ask is whether the NHS is financially broke and whether it can possibly go on being funded from general taxation. Now, we hear a lot about the financial problems of the NHS at the moment, but I just want to take you back to when they started, which was 1948. Which was in 1948, because the NHS budget doubled in its first 2 years, and right from the start there was panic about what we were going to do about escalating costs. And clearly one of the things that can be done is to encourage people to make responsible use of the service. And certainly when I turn on the television in my region in East Anglia, quite regularly in the winter I see one of my A&E consultants looking weary, standing outside saying, please make responsible use of the NHS, especially during these winter months. So the next clip is from 1949 and is a Labour MP encouraging the public to do just this.
And I pretend I'm gay, I never feel that way, I'm only painting the clouds with sunshine.
So far, the National Health Service has been getting along remarkably smoothly, indeed far better than we had dared to hope. Millions of you have got those spectacles you need, and tens of millions of you have visited the doctor under the scheme and got your medicine. Provided we're reasonable in our demands, particularly during the coming months when always at its heaviest, there's no danger whatever that the National Health Service will break down.
I think you could imagine that being said by almost every Minister of Health between then and now. So what on earth were they going to do about escalating costs? Well, the first thing that Bevan did in 1950 was to get a senior civil servant to review things and make some recommendations as to what could be done. And Cyril Jones chaired that committee, and he wrote there's a fundamental incompatibility between central control and keen and public-spirited individuals who bear no responsibility for providing the funds and cannot be called to account for those who have to pay the bill. So he made a set of recommendations. One is that hospital management committees should be subject to direct control from the Ministry of Health with outposted civil servants. Two, that GP prescribing decisions should be reviewed by lay managers, and that doctors should be excluded from the management authorities of the NHS. And Bevan's comment on that was, frankly, I did not consider the battle worthwhile. So nothing was done at that point. But costs continued to go up, and Aneurin Bevan resigned from Minister of Health with the introduction of charges for spectacles and for dentures. He thought this was the thin end of a wedge, which would essentially undermine his fundamental principle on which the NHS were founded. Bevan resigned, the NHS went on, its costs continued to go up. And the next person who had a go at dealing with addressing rising costs was C.W. Gillibo, who was an economist at Cambridge, and he chaired a commission on future funding of the National Health Service. And the Committee of Inquiry was given this remit: to suggest means of ensuring the most effective control and efficient use of exchequer funds while providing for the maintenance of an adequate service. So those were his terms of reference, and I'm going to read out a significant chunk from the report, because this report in 1955 could be written now in 2017. So he was asked to look at providing an adequate service, and he wrote, if the test of adequacy were that the service should be able to meet every demand which is justifiable on medical grounds, then the service is clearly inadequate now. Nor is it clear that such a service, even if it were to become adequate by this criterion, would remain so without continually increased expenditure. The growth of medical knowledge adds continuously to the number and expense of treatments, and by prolonging life also increases the incidence of slow-killing diseases. We conclude that in the absence of an objective and attainable standard of adequacy, the aim must be to provide the best service possible within the limits of available resources. And I don't think we could give a better summary of the issues around the financing of the NHS than that, though we have changed our terminology in terms of slow-killing diseases have become long-term conditions. And over the years, successive ministers and secretaries of state have thought there must be a better way of doing this. And you recall the quote I gave you from the 1926 Royal Commission, that the ultimate solution would lie in the NHS being supported from general taxation. But ministers have successively sent their civil servants around Europe and around the world thinking there must be a better way of doing this, and looking particularly at insurance systems. And Norman Fowler in 1991 concluded, in many ways, our centrally financed system is the most effective in controlling costs. And Nigel Lawson in 93 said it didn't take us long to conclude that there was surprisingly little we could learn from other systems. To try and change to any of the systems in use overseas would simply be out of the frying pan into the fire. And it perhaps won't surprise you that the person who thought about the most radical change was Margaret Thatcher. And she suggested the possibility of replacing the National Health Service with private insurance, and there might need to be a compulsory minimum for everybody, but charging for visits to doctors and charging more for drugs. The backdrop of this slide is a copy of The Economist, which leaked this internal memo, which caused an absolute furore, and that proposal never saw the light of day. And that, in a sense, demonstrates to you, and we'll see it again later, the huge political risks of tampering with the basic principle of the NHS of being principally free for all at the point of delivery. But these sorts of suggestions continue to be made. Here's one from some recent doctors in an article just this year, with Carol Sikora and 60 doctors signing a letter saying that radical measures must be debated because standards of care are increasingly poor by international standards, and suggesting insurance to cover what we would call basic NHS services and co-payment for other services. And I'll talk more about the risks of doing that a little bit later. I next want to go on to the issue of how the NHS is managed, and in particular, the issue of managing doctors and doctors as managers. And I partly bring this to this audience because I think we bear a significant responsibility for some of the things that haven't gone quite as intended. The issue of management of the NHS was brought to the fore by the Griffiths report. Roy Griffiths was chief executive of Marks and Spencer's, and he wrote in his report, if Florence Nightingale was carrying her lamp through the corridors of the NHS today, she would almost certainly be searching for the people in charge. And this led in 1983 to the introduction of general management in the NHS, and of course, then the potential for performance management. And we have all suffered, experienced, evaluated, got our livelihoods from evaluating performance management in the NHS in one form or another. And of course, we have also been significantly responsible for giving people and the NHS the tools to do so. So health service researchers have been demonstrated the wide variation that occurs in clinical practice almost wherever you look. So in this slide, there is tenfold variation in the rate of knee arthroscopy in different parts of England. And when we got clever enough to develop methods of measuring quality of care, we could get similar atlases for quality. This slide showing tenfold variation in the quality of diabetes care in different parts of the UK. And this, of course, has been not a UK effort, but an international effort with some very significant publications, such as this one, Crossing the Quality Chasm in the Institute of Medicine, articulating the large gap that exists between care that could be provided and care that was actually provided. And we have provided much of the research and much of the background data needed to understand this big gap that then we have been successively trying to fill. But of course, you do have to be a bit careful what you wish for, and Murphy's law is that anything can go wrong will go wrong, and if you want to take a somewhat more academic view of this, you could do much worse than reading Robert Merton's 1936 paper in the American Sociological Review on the unanticipated consequences of purposive social action. And I just want to give you two examples, and they're both examples where we as health service researchers have contributed to things that haven't got quite as intended. So first of all, NICE guidelines. Now, many people in the room have either been involved in developing NICE guidelines or use them. We don't just have one NICE guideline, we have lots and lots of NICE guidelines. And one of the critiques of guidelines is that they have been often developed using the results of randomized controlled trials, which have been developed on people with single conditions, often excluding people with comorbidities, often excluding the elderly, often excluding women, and indeed not very representative of the people who actually pitch up day to day with the NHS. So that has produced, maybe backlash is too strong a word, but the BMJ's Too Much Medicine campaign and the equivalent Choosing Wisely campaign from the ABIM Foundation in the US, which articulate that developing 20 guidelines and applying all the recommendations in those guidelines to the poor old person in front of you who's got those 20 conditions doesn't always end up with correct and rational treatment. And we start to have a move against this. So the most recent NICE guideline on the management of multimorbidity includes taking account of the patient's individual needs and preferences, the burden of treatment on their lives, and the benefits and risks of treating multiple single conditions. So we can see a move away from, as it were, slavish following of guidelines towards involving patients in decisions about their care and giving doctors more responsibility for what they actually advise and discuss with their patients. My second example relates to performance management in general practice, and in particular to QOF, because the availability of quality indicators gives government the opportunity to performance manage primary care, and most of you will be familiar with Quality and Outcomes Framework, which was introduced in 2004. I'm not going to give you, that's another lecture I can do on the pros and cons of QOF, but just to give you an example of an unintended consequence of a well-meaning action. At the time the QOF was introduced, patients were having a lot of difficulty getting to see their doctor. People often waited 2 or 3 weeks to get an appointment. So an indicator was introduced in the original Quality and Outcomes Framework that provided a financial incentive for people who could, practices which could see patients within 48 hours. And the response of many, in fact most practices to this, was to introduce some form of a scheme called advanced access, which was to offer unlimited appointments on the day, but then reduce or deny completely capacity to book ahead. So patients often could not book ahead and could only book on the day, and so the government's target had been met, but many patients actually found it harder to get an appointment. And this is such an obvious consequence, everybody knew about it, except possibly one person. And this next clip demonstrates why politicians don't like doing live election broadcasts.
Yes,
Yes,
you're actually putting forward targets on practically everything for timescales. I can't get an appointment with my local GP unless it's made within 48 hours. I can't make it 3 days or 4 days hence. I was told that's because they can meet their target that everybody gets it within 48 hours. Why?
Well, I'm absolutely astonished at that. I mean, look, come on, let's be sensible about this. I don't know about this individual case, obviously, but I would be absolutely astonished if you're saying to your GP, I don't need to see you for 4 days, and he's insisting he sees you in 2. The reason...
The doctor is asking you to come back in a week. You can't make the appointment in a week because you're only allowed to make it 48 hours beforehand. This is my son's appointment last week. You have to sit on the phone for 3 hours in the morning trying to get an appointment because you're not allowed to ask for the appointment before that, because by making it 48 hours beforehand, they're meeting the government target.
Is this news to you? I have to say,
hold on.
That is news to me.
I think you can work out that he probably doesn't make his own appointments to see the GP. So, we'll move on from the trials and tribulations of performance management, because QOF has now been abandoned in Scotland altogether and is going to be substantially revised in England. In Scotland, they have moved over to a scheme which essentially puts quality improvement activity absolutely back in the hands of GPs with very little external control. And NHS England is currently debating how much they can bear to lose control. And that's a discussion for another day. But let me just briefly talk about doctors and their role in management. Roy Griffiths' report originally said that district chairmen should involve clinicians more closely in management. Clinicians must participate fully in decisions about priorities, and clinicians need a fully developed management budget approach. But they've been very ambivalent about this. And a quote from Ken Clarke, when he was Minister of Health, illustrates this very nicely. He's describing going to Ely to discuss the closure of the maternity hospital. And he writes, "A great demonstration took place outside, and they were moving babies inside to try and give me the impression that there were more than there were. I met with the grand consultants who told me ferociously, addressing Minister of State in an absolutely James Robertson Justice-like way, that I'd got to close the place. They were not going to accept any more referrals. It was dangerous. So I said, come out with me and say that to the television cameras and all those women waving babies at me. And they refused. Absolutely refused. They said, that's your job. We're not prepared to do that. It was my first introduction to the fact that some of the medical profession had no time for those who had to manage the service, yet were not prepared to accept responsibility for managing change." And that, of course, is nothing terribly new. Back in 1920, the chief medical officer, in actually the first CMO report that was ever written, wrote, "The status seen in the profession, a body insistent on the privacy and individuality of its work, the sanctity of its traditions and the freedom of its engagements. The profession has seen in the state an organization apparently devoted to the infringement of these traditions and incapable of putting anything worthy in their place." Again, I think we see that some things don't change very quickly. So finally, I've entitled my lecture History of NHS Politics up to 2030. So let me now give you a few predictions for the future. But as a preamble, we do beat ourselves up. Here's Enoch Powell, Minister of Health in the 60s, talking and saying the NHS presents what must be a unique spectacle of an organisation that's run down by everybody engaged in it. Because actually, we still do very well by international standards. Here's a study from the Commonwealth Fund comparing 11 healthcare systems. And in terms of rank, we come first, second or third on just about every aspect of care they looked at, except healthy lives, the bottom one, outcomes, where we still do significantly worse. So, for example, Sweden has double the infant mortality that we have. But we continue to run it at very low cost compared to most other countries. And indeed, we still have, and I'm sure many people in the room have experience of people coming from abroad to look at how the NHS works, seeing examples of things that they would like to emulate in their countries. As Bevan indeed said in himself, he said, the eyes of the world are turning to us. We now have the moral leadership of the world, and before many years we will have people coming to us as a modern Mecca, learning from us in the 20th century, just as they learned from us in the 17th century. And I think that that is something which we have all seen, despite the fact that our daily newspapers are still filled with parlous tales of how bad the NHS is. And if you look abroad, if you look at the problems that other healthcare systems are facing, they are in fact exactly the same as the ones which we face. They're around escalating costs, they're around giving patients choice, they're around the increasing number of elderly, the place of competition, how you measure and improve quality, and the role of incentives. So these things are common to many countries around the world. So if I go back to my crystal ball, first of all, I'm afraid we will continue to see reorganization, or redisorganization, as some commentators have called it. And we do suffer from a political system where our masters think that if only you could rearrange the deck chairs on the Titanic, somehow it would be all right. So to imagine that we will not be subject to continued reorganization is unfortunately fanciful. I think we will have a continuing debate about the role of clinicians in the NHS and their role both in terms of performance, how you performance manage clinicians, but also their role in managing. I think it's something which we, as a country, still feel very ambivalent about, both politicians and clinicians, and maybe the wider public. There will be continued discussions and arguments about money. The NHS, you would think from reading the papers, is a very expensive service. But it's not in international standards. This graph from OECD figures shows the number of practicing physicians per 1,000 population. We are towards the bottom there with the blue line. If we had as many doctors per head of population as Germany, we would have 69,000 more doctors in England. And if we had as many doctors as France has per head of population, we'd have 27,000 more doctors in England. Now, I don't want to argue that Germany or France necessarily make efficient use of their doctors. They may indeed not do. But we should not forget the fact that by international standards, our health service is now starting to look pretty cheap. The next thing is that we will face increasing pressure for integration with local authorities as the pressures on the NHS become so obviously tied up with the pressures on social care. I guess most very obviously in the last 5 years with cuts to social care budgets, putting very, very greatly increased strains on the NHS. And that is absolutely something which governments have not yet tackled, but will continue to be a major issue. And then finally, people will continue to seek some better method of funding. Is there going to have to be a place for co-payment? Are we going to have to define what an adequate service is, and that is what the NHS can provide? And there will be continued issues around the role of public versus private provision. But it is a hugely risky area for any politician to get into. When David Cameron took over leadership of the Conservative Party, it was actually Conservative Party policy at that time to introduce a thing called a patient passport, which basically said that if anybody had an operation in the private sector, they would get 50% of the cost of that reimbursed. And I mean, in some ways not that radical a suggestion. It happens in Austria, it happens in Finland. But when Cameron took over leadership of the Conservative Party, he saw that as a significant political risk, and he simply dropped that as Conservative Party policy. And if you want any more evidence of the intensely political nature of the NHS, listen to this 91-year-old talking at the 2014 Labour Party conference.
I still remember hearing, while I played as a child on my front step, the anguished cries that floated from a nearby neighbor's window. They were the screams from a woman dying from cancer who couldn't afford morphine to ease her passage from this life. No one in our community was safe from poor health, sickness and disease. We must never, ever let the NHS free from our grasp, because if we do, your future will be my past. I am not a politician, a member of the elite, or a financial guru, but my life is your history, and we should keep it that way. So say it loud and say it clear in this hall and across this country. Mr. Cameron, keep your mitts off my NHS.
So the message to politicians is basically this. And I don't think we can see any prospect of any significant change unless there were to be consensus between the major political parties. And throughout the whole of the NHS history, the two major parties have seen the NHS as something which they could potentially score points over. So I don't know where we would need to get a real consensus between the political parties. So we have a huge number of challenges which we could help address as health service researchers. I could have thought of 5 slides, but here's just one slide. What is it worth spending on healthcare? Is the amount we spend about right? Should we be spending more? Is there a political argument for spending more? We have pretty poor measures of quality of care. Can we develop better measures of some of the important things which we don't currently measure, coordination, patient-centeredness. But even if we had those measures, we have a very poor history of actually moving from quality measurement to quality improvement. Why is there such a poor link between those? How do you balance evidence, clinical judgment, and patient priorities? And what is the role of clinicians going to be in 2030, when the role of patients is most certainly going to be very different, with patients having access to much more information about their care and their conditions? How can we learn better from other healthcare systems? Because we spend quite a lot of time observing other systems, but taking relatively little learning from them. So I finish with this picture of Galatea, who is Salvador Dali's wife, and just ask you what you see here as an allegory of the NHS. So do you see a picture of a beautiful woman just coming together into a model of perfection, or do you see a beautiful picture which is fragmented and falling apart? I think if I look to the future, I see neither of those things. I'm afraid I see us muddling along for all the reasons which I have described. I think that many of the problems we face now are those that we faced in the 1940s and 50s, and I fear that the best we can do probably is to keep doing the best we can within the available resources, as that Cambridge economist said. Thank you very much.